My name is Yvan Beaussant. I'm a hematologist and palliative care physician. Sorry, and yeah, I'm sorry I cannot be with you today. I was really looking forward to coming to the Breaking Convention conference, and I had to cancel my trip on Monday because of COVID. So I'm a late joiner of the multitude who had COVID now, and I'm now recovering from my symptoms. But I'm glad I'm able to present today. And I'm really thankful to the organizers of the conference for allowing me to present and accommodating this remote presentation. And I should probably share my screen to continue my introduction and my talk. Does that work? Great, thank you. Okay, and so as I much rather be here with you and learning and partying with other psychedelic passionates. But I'm very glad to present some of my work today. And please, you can see my email here in the slides. Don't hesitate to contact me if you want to learn more or to be in touch. So I'm a hematologist and palliative care physician by training. I was originally trained in France. And I live and work in Boston now, where I conduct research on psychedelic-assisted therapies at Dana-Farber Cancer Institute and Harvard Medical School. And so today I'm presenting a qualitative study that I conducted with colleagues to explore the acceptability of a group approach of psilocybin-assisted therapy in patients with cancer and major depressive disorder. And so this study is entitled Acceptability of psilocybin-assisted group therapy in patients with cancer and depression, a mixed method study in participants of a phase 2 trial. And this study was made possible by a research grant from SENS. So as a hematologist and a palliative care physician, unfortunately, I'm well aware of the burden of psychosocial and existential distress in patients with cancer, and in particular, depression, which affects around 20% of them, and in most studies, and really negatively impacts quality of life, adherence to treatment, meaning people's capacity to engage in cancer treatment and self-care. It impacts survival and family bereavement and overall healthcare costs. So I'm a firm believer of the importance of integrating interdisciplinary psychosocial and palliative care early into cancer care to address these needs of patients and families confronted with cancer. And we've made really great progress over the past few decades, in trying to do a better job addressing the people that are around the cancer. And however, our pharmacological and psychological tools, and also the psychological and spiritual care that we're able to provide to patients remain often limited to alleviate significantly depression. So, in the context of the current psychedelic renaissance, as you all know, there's been like a growing evidence of showing the potential benefit of psilocybin-assisted therapy to address anxiety, depression, and existential distress in patients with cancer. So these are the work of NYU and Johns Hopkins and UCLA, looking at psilocybin-assisted therapy in this patient population, and that really contributed to the current renaissance we're in. And yet, in this model, that was really in these very carefully conducted studies in psychiatric labs. So the individual treatment model that was developed requires substantial resources, including multiple sessions attended by 2 trained therapists to prepare for and to facilitate and debrief the drug administration. And the cost of individual therapy and the scarcity of trained personnel, trained therapists, limit the scalability. So it's not a new problem in psychosocial interventions in cancer care, where individual interventions have often been adapted for group delivery, once developed. And in addition to that, psychedelics are already most commonly often used in group approach, in ceremonial or community use. So it makes sense to move and develop group approaches of psychedelic-assisted therapy, including in the medical model. And that's really what the study here was about. And so the original study, the clinical trial that we worked with, was conducted in Maryland at the Aquilino Cancer Center in a treatment space that's really embedded in an oncology community clinic. And so it was purpose-built for psychedelic-assisted therapy and research and other mind-body interventions in the cancer space. So you can see some of the pictures here of how it looked like. It has been built between 2019 and 2020. And so then they were able to start the first clinical trial that is the one that we're going to talk about today. And so the parent study, I call it the parent study because that's the study that enrolled participants who received psilocybin-assisted therapy in the context of major depressive and disorder and cancer. And so these are the patients that we interviewed to further understand the acceptability of the group approach. So the clinical trial was a phase 2 open label trial. The primary outcome was safety and tolerability. Secondary outcomes were on the efficacy on depression using the MADRS scale. And then there were several exploratory outcomes on anxiety, pain, quality of life, demoralization, and healing. And so patients received one dose of psilocybin-assisted therapy, 25 milligram, which corresponds to a moderate to high dose. And the clinical trial enrolled 30 patients with advanced and non-advanced cancer, and who were treated within cohorts of 3 to 4 participants. So these were the group that we were working with. And I'm going to tell you more about that so that you can understand how it works. So this is the study schema. You can see the screening and then 2 prep sessions, 1 dosing session with the psilocybin, and then 2 integration sessions. Then the follow-up period and the quantitative assessment was up to 8 weeks after the dosing day. And then the interviews occurred 2 to 3 months after the dosing. And so this is how prep 1 works, with these cohorts. So prep 1 was individual sessions with 1 single therapist, but all those individual sessions were conducted simultaneously. And the 2 therapists that you can see in brown here are in a sort of control room here. So these are Bill Richards and Brian Richards, who are overseeing all the therapeutic sessions going on at the same time. And here is an example of the individual session in one of the rooms. Then the prep session 2 is so this happens about a week before dosing, and this happens the day before dosing. And during prep 2, participants have a group session that lasted 75 minutes, and then again another 45 minutes of individual therapy time with their therapists. So that's prep 2. And here you can see a photo of the group space. So the participants are not here, but you can imagine that you have the 4 participants and there are 4 individual therapists, plus some of the researchers or lead therapists. So it's like easily 10 to 12 people in this room, including the 4 participants. So this is the psilocybin session, 6 to 7 hours of simultaneous administration. So again, participants are in their individual rooms with their therapists, and the two lead therapists are overseeing the sessions in the control room, and they can intervene and or join for support or replace the therapist as needed. You know, if the therapist needs to take a break, and so there is it allows the lead therapist to oversee the sessions and to help as needed. And then the two integration sessions happen just very similarly than the prep session 2, with a time of group therapy of 75 minutes, and then simultaneous individual therapies with each single therapist. And so that was for integration 1 and integration 2. So I'm going to very quickly present some of the main findings of the parent trial. And these were just published in a research letter in JAMA Oncology last week. So you can access this online. And and so the cohort of participants really stick through the trial. You know that the attrition rate was 0%. So no participant dropped out of the study. The mean age was 56-year-old, and there were 9 men and 21 women in this trial. 14 participants had curable cancer, while 16 had non-curable cancer. And all of the sample reported, half of the sample reported previous antidepressant drug therapy. And 11 of them reported prior psychedelic experiences. And most of these were done several decades before the experience, you know, like classically when people were in college or high school, have had some psychedelic experience, but I think none of them had like experiences of intentional or therapeutic use of psychedelic assisted therapy. So in terms of safety, there were no treatment-related serious adverse events that occurred, no suicidality based on the CSSRS, and the main adverse events were mild and or expected, and they included headaches, nausea, altered mood, anxiety, and hallucination. And so here you can see the curve of the MADRS scores, you know, following psilocybin treatment, with a baseline that was around 25, and that dropped below 10 in a sustainable way, you know, at week 8 post-treatment. And overall, there is a sustained response rate of 80% in this cohort. So meaning that 80% of patients had more than 50% of decrease of their MADRS score from baseline to week 3 and week 8. And 50% of this cohort, meaning 15 patients, had a complete remission of their depression as measured as a score of 10 or less on the MADRS score. So these are really good results, especially in a population of patients who were maybe cleaner in terms of diagnosis of depression than in previous studies in the cancer space, because they really had major depressive disorders diagnosed by clinicians. And here's some quotes that illustrate some of the effects on patients on psychoexistential distress. This patient said, by the following week, my angst, my intense anxiety, this feeling of keeping the dam of emotions behind something, there was nothing. It was like, okay, you know what? It's fine. Another patient who speaks about how the intervention helped her with coping. She says, I'm much, much better. I know that I have meaning from my meditation and the time that I spent with people and the time I spent in nature. I found my meaning, and it feels endless. It's not a project. It's endlessly available to me. I'm not really happy still about having cancer, and I'm terrified still, but I can observe that fear and those emotions without them ruling me. Another one that touches around spiritual well-being and end of life. This patient says that I realized that I can die without having to give up that sense of being well loved, that I have everything I need. And to balance a little bit, because not all the patients responded or had a remission of their depression. Some of them were disappointed, like that this patient, about the effect on anxiety and depression. So she says, I am a little bit disappointed that it didn't do much for my depression and anxiety. It helped in many ways, as I've talked about, but I do still have those. The cancer is real. And when you hear distressing news about it, it is real and it's there. So what she's referring to is that she had the intervention really helped her with nature, actually. And she had like a strong sense of connection with nature afterwards, and also really helped her improve her relationship with her husband. But she still had her depression, anxiety symptoms, which so we're still analyzing all those results. But I think several of these patients, like might benefit from iterative dosings in addition to this one here. So raising all questions around follow-up, etc. And so remarkably, all patients really described some benefit, even if they were still having anxious or depressive symptoms, they all got something out of the intervention that was meaningful for them. And there is this very nice paper that came out around this same study that presents the results of the how people responded in the HEAL, NIH HEAL measures, which measures healing. So I encourage you to look at this paper. It's very interesting. So getting back to the qualitative study, and I want to present you some of our findings, around acceptability of the group approach. Got it. Thank you. 10 minutes. I tried to write. So that's good. So our interviews occur between 2 and 3 months after the dosing sessions. These were semi-structured interviews that lasted about an hour and a half with the participants. We were able to interview 28 out of the 30 participants, and we audio recorded the interviews, transcribed them. The analysis used an online software called the and we used a conceptual framework of acceptability that has been published by Secon now. And that looks at acceptability through 7 constructs that are the affective attitude that people have about the intervention, the burden of the intervention, the efficacy, meaning how it aligns with people's values and how it fits with their values. Then the intervention coherence, how people understand, how it works, the opportunity costs, the perceived effectiveness of the intervention, and the self-efficacy. And you can look at acceptability from a prospective way, and then the concurrent acceptability and the retrospective acceptability. So here we're mostly asking patients retrospectively about how they felt about the treatment. So the way we looked at acceptability, so we have a lot of data. We looked at acceptability. We looked at other constructs, around participants' experience of psilocybin. So today I'm really going to focus on what people said of their experience of the group and the simultaneous approach, because that was our primary research question. And there will be other work, or presentations on the acceptability of the psilocybin experience itself, and then all the range of patients' experience of psilocybin and the importance of set and setting. There's a lot of data on that. So first, in terms of acceptability of the group simultaneous approach, people describe that the group going through the psilocybin study with other cancer patients felt reassuring and increase their sense of safety, for many of them. So it enhanced people's sense of safety and sense of preparedness to the psilocybin dosing. So one said, I think it was definitely better to do it in a group. It makes it less scary. You're not alone. And that makes sense because, for many people, this was a new experience. They had never had a psychedelic experience before. So for many of them, it was like a leap into the unknown, to uncharted waters. And so they were anxious about what might happen during the session, like would they be losing control or feeling overwhelmed? What would that expose them to psychiatric or medical complications? So listening to other participants' stories and hopes and fears during the prep sessions, and having others' questions answered by the therapist help them feeling more prepared for the dozen day. So this quote says about that. Yeah. Then the second theme was how the group approach contributed to the therapeutic efficacy. And we have like three ways people reported that the group approach really helped them in terms of efficacy. One way is that it enhanced their sense of connection with themselves, with others, and then sense of belonging. And most of them felt really immediately comfortable with the group, and they appreciated the opportunity to connect and to share with others prior to the simultaneous psilocybin experience. So, they found meaningful common grounds with others, and a sense of being together in that. So, for example, this patient says, I knew that they all had cancer, and I knew that they all had depression. With that alone, that created a little group that I was very comfortable in. And another one says, the group integration helped a lot. You're part of a community that's suffering and healing together. Yeah. On the other hand, it was more challenging for others, patients, with some having a initial feeling of awkwardness or nervousness with the group. And yet, for all patients, they noted that such feelings tended to dissipate after the psilocybin experience. And then they really realized how they felt connected with the group and how integrating together was helpful. So maybe I'll just read the beginning of that one, but this one was less comfortable. She says, I don't do well in group settings. It was awkward for me. In preparation before, I just thought was awkward. I had group trouble connecting with people anyway. I didn't feel really like I was connecting with people. And then she goes ahead and says that she was feeling, much more connected and much more help in the integration after the dozen day. Then participants said that the experience enriched and deepened the meaning that they got from the experience. So I'm just going to read this quote. Having input from these folks and hearing their stories, the stories of other participants, absolutely. I think without that, just going home and not talking to anybody, things would have faded quicker. Having someone to bounce off ideas and feelings, emotions that came up was really helpful. And finally, people really derive benefits from a sense of compassion for others and of self-transcendence, like during the experience of psilocybin within a group, help them go beyond, decenter from their own individual narratives and transcend self-boundaries, in a new compassionate appreciations of difference. And these patients say it was amazing to see the transformative type of mental process that went on there. I'm so happy for her. That's the other thing. It elicits compassion for other individuals, people that you would normally have not normally have anything in common with. Now you have in common with. And so the third big overarching themes, of acceptability of the group approach is, encompasses different factors that influence this acceptability. And so the first of one is people really highlighting the importance of the therapeutic framework, meaning the presence and the input of the therapists, the researchers, during the group sessions. And that was critical to help them feel safe, comfortable, open, and to create this, so when patients say, like a professional, accepting, and kind and non-judgmental space. And this is a beautiful quote of a patient. She says, to feel in these concentric circles of being so well cared for by the therapist in the room with me, by the people who are part of that team, by my family and friends, my oncologist. There's so many layers of it, so many layers of feeling well cared for what we're every bit as much a part of the experience as confronting the painful reality of death, both in the physical pain and the psychological pain. And people highlighted the value of individual sessions in addition of the group sessions. They highlighted a complementarity between both. And so I'm not going to read the quotes because I'm running out of time, but there is really a question about hybrid models here, because for some people, like this one, having individual sessions was really, really important, and especially for the dosing day. Like she was saying, like I would have been too guarded off, if I have done the psilocybin experience within a group. So it was good for her to be in her private room with a single therapist. Then some patients mentioned that they could hear others, during the simultaneous administrations, crying or talking. So, that kind of became part of their trip or their experience, but for some of them, it was also distracting. And patients highlighted, some potential disruptive factors within the group. For example, the number of participants. Some of them say there were too much staff in their group. Then the group also, lead to some people comparing their experience to others, which people reflected upon. And then people reflected also on the fact that I'm almost done. Thank you. That being in this, in the same group than people with very different stage of cancer. So like early stages cancer with people who are much more advanced and vice versa. We had some reflections from patients who were saying that they're having somewhat disturbed by that, and triggered somehow. So all good thoughts for reflections. And then this last idea is that in terms of connection, and the group size and the structure of interactions, some patients, really wanted more relationship, more connection with their group, than the structure of this clinical trial allowed. So, giving us ideas about it, really creating more opportunities for group interactions like peer support. So just to conclude very quickly, like this study really shows that the acceptability and the feasibility of this model of integrated group and individual psilocybin-assisted therapy. What's remarkable is that it happened in a community cancer care setting and in patients with diverse cancer staging. The group approach may contribute to participants' sense of safety and efficacy, but there are questions, that emerge from this study. Is it for all patients? Should we have more homogeneous groups, different sizes of groups? And then the value of having hybrid models that mix individual and group treatments, and really fostering group interactions between participants. So we definitely need more clinical trials. And I'll just end with this definition quote that comes from an international consensus on spirituality in healthcare, and that defines spirituality as a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred. And so in many ways, our results around how the group approach enhance connection, meaning, and transcendence resonates with this idea of integrating the spiritual dimensions into healthcare much more. So thank you so much for your attention. These are the people who have contributed to this work. And I'm really glad to, if you want to reach out and if you have questions, I don't think we have time now, but I'm happy to be in touch by email.